It's a real pleasure to be here to share some stories about things I'm passionate about. And like Dr. Madison, I want to thank Dr. Kraft because I've been to Future Med, I think, 3 or 4 times now. And in addition to the roles you see there, I also serve on advisory boards for several startup companies. And I think about half of them were either started out of here or people who I met through Singularity and Future Med. So it's a real privilege. So this talk is going to contrast strikingly with John's talk because he was talking about Kaiser, a huge organization, and I'm going to talk about one tiny little children's hospital up at Stanford. But it's a nice segue, the child health advocacy that you finished your talk with, John, because the hospital where I work serves only children and pregnant mothers. We're about the beginning of life, and in fact, we're a really unique hospital in several ways. One is that we do more solid organ transplants in children than any other hospital in the United States, than any other hospital in the world. In fact, 10% of our patients at any given time are Kaiser patients because we have contracts to do all the solid organ transplant for Kaiser Permanente. We also do unique congenital heart surgeries that aren't done anywhere else in the United States. And so as a result, we tend to rank sort of highest in the acuity of our patients across the nation. So this is 42 different children's hospitals, and we consistently sort of rank as the sickest hospital, which doesn't mean that our sickest patients are more sick than anyone else's, but that we don't have very many not sick patients. In fact, we did more stem cell transplants last year than we cared for children with asthma. So it's a really unique environment, and when I finished training here about 13 years ago, I had the opportunity to join our electronic health record implementation, and I love the place, but I had seen some really unfortunate things happen during my training. Here's one example. And you can see what I'm talking about when the orders are written on paper. You've all seen examples like this. Well, this is a real example from our hospital. I didn't write this order, but it was written while I was training there. You can see this is a newborn because the first order is an echo to rule out a persistent ductus. We've got some clinicians in the audience. What about that third order there? What's wrong with that? 2 things. So, abbreviation of morphine versus magnesium, and 0.1. Turns out there's actually 3 things. The Institute for Safe Medication Practices will say you can't use a range like that, Q2 to 4. But unfortunately, it was that leading 0, or the absence of leading 0, that actually caused harm one of our patients. So it was written at nighttime. The full milligram of morphine for a premature infant was dispensed by a pharmacist, and a float nurse actually administered it. That baby was re-intubated, had the breathing tube out, had to have it put back in because the child stopped breathing. And this was the kind of harm that we were looking to prevent when we put our electronic health record in, so that we could provide automatic dosing guidance. We also have issues with documentation. In fact, the documentation before we put in our electronic health record looks something like this. On the right-hand side, you see an anesthetic record. On the left-hand side, that's actually not from our hospital. That's from Boston in 1895. That was Harvey Cushing's original anesthetic record. So you can see documentation has changed very little in over 100 years. Now, of course, it's digital, it's discrete, it's graphical, it's viewable, and we make decisions in a different way. Now, this implementation occurred around 2007, and so you can imagine my horror when the bomb dropped in 2005. When another children's hospital implementing the same software that I was hoping to put in, that I had given up 75% of my clinical career because I believed that it was going to help more children than I could touch personally. 75% of your clinical career is a lot of time. I spent a lot of time putting this system in, and yet Children's Pittsburgh published a paper saying that around the same time the implementation of the electronic health record, they saw a bump in mortality, an increase in mortality. There was a lot of arguing about whether this was truly a cause and effect. It was retrospective, but nobody argued with the statistics that showed at the time that the physician order entry system went live, there was an increase in deaths among a subset of patients transferred from outside hospitals. So you can imagine my relief when 3 years, actually 18 months after our implementation, our chief quality officer, Paul Sherrick, called me up and said, "Dude, you're not going to believe this." He's from Southern California, so he says dude a lot. He says, "Dude, our mortality has been decreasing since we went live." He says, "In fact, I just ran some simple statistics. We got a statistician to run some more complex statistics. They held up. Even using acuity adjustment, we estimated 36 children's lives were saved over the 18-month period. The Institute of Medicine, in their 2012 report on health, IT, and patient safety, recognized these two manuscripts and said, it's not about the software that you're putting in, it's about how you implement it and how you change processes. So why did we get a different outcome than our colleagues at Children's Pittsburgh with the same system? We did things a little bit differently. They centralized their pharmacy and didn't have order sets available in their intensive care unit. We had an ICU doc as part of our program and tested it live on real patients before the system went up in parallel. We did a lot of things differently, and so we were very relieved to have this kind of outcome, but this is the beginning of the story, not the end. Since 2007, when our system went live, we've been feeding a very large database at Stanford. It's called STRIDE, the Stanford Translational Research Integrated Data Environment, meant to support clinical research. We've been feeding it with everything from ICD-9 codes to lab test results to full text documents. It has 115 million labs from our hospitals. It has 22 million documents, free text. And this is really important in the story because 2 years ago, something different happened. 2 years ago, my colleagues and I admitted a 13-year-old girl with a known diagnosis of lupus. This girl came in with lupus flare as illustrated by nephrotic range proteinuria, some pancreatitis, other concerning lab findings. My colleague, Dr. Frankovich, also somebody that trained with Dr. Kraft and I, asked a really smart question. She said, I wonder if this girl is at higher risk for clotting, and should we anticoagulate her? So we did what any good evidence-based clinicians would do. We went to the literature, looked it up, and of course there's nothing in Medline, nothing in PubMed. So we did what evidence-based clinicians do next. We asked our colleagues, get that anecdotal evidence. And the first pediatric rheumatologist we asked said, absolutely, I saw a case of a girl just like this who clotted a few years ago. No question I would anticoagulate. And the next one we asked said, absolutely not, never, risks are too high. In adult medicine, you anticoagulate everybody who's not actively bleeding. In pediatric medicine, the risk-benefit ratios are very different. So this is when Dr. Frankovich did something that had not been done before. She went to that STRIDE database, and she queried our institutional experience for the last 5 years. She said, rather than looking at a slice of the pie like each of our pediatric rheumatologists and pediatric nephrologists are doing, what if we look at our whole institutional experience? And on the day that this girl was admitted, we constructed a cohort of 98 patients just like her. We created the cohort with ICD-9 codes, with lab tests, discrete data. But then we wanted to look at the outcomes, and in order to look at the outcomes on who had clotting events, who didn't, we had to go to the text. So we had search terms like thrombus and thrombosis, and it would have been very nice, Dr. Madison, to have the NLP team helping us at this point. But we used the text to construct the outcomes, and we found that, in fact, children like her were at 7-fold higher risk of clotting than children with lupus without these lab findings. And based on that, we made the decision to anticoagulate. Well, here's the rest of the story. After this paper was published, somebody from the STRIDE database department said, you know, this really wasn't what the database was intended for. It was intended to support clinical research, not patient care. IRB was called, legal, compliance, risk management, and the dean's office. We had a very tense 24 hours. It was suggested that perhaps the New England Journal article should be retracted. And then legal weighed in and said, there's nothing illegal here. Compliance weighed in and said, you know, there's nothing from a regulatory standpoint that this is violating. Risk management weighed in, and to their credit, risk said, you know, this is why people come to Stanford, is for the benefit of the experience of caring for these children that aren't getting care elsewhere. And finally, IRB weighed in and said, this wasn't exactly what your initial IRB for review of the data was intended for, and you should come do a mea culpa. wink, wink. This is changing things. I know we're going to hear from somebody later in the week about Patients Like Me, that allows patients to go put their own information in and understand aggregate data. We know that electronic health records can cause as many problems as they solve, and we saw that in Dr. Madison's talk. But what we're not doing with those EMRs today is giving people the benefit of all the other data that's in there. I, as a clinician, want a button in my EMR that says Patients Like Mine, that allows me to construct a real-time cohort of similar patients and identify the outcomes of those patients to help make better data-driven decisions and recommendations in partnership with my patients. In fact, the next Institute of Medicine report in 2012 on the learning healthcare system cited this paper as a key example of how clinical decision support needs to evolve from pop-ups and alerts to much more sophisticated support of decision-making in the clinical setting. They said that decision support tools and knowledge management systems should be routine features of healthcare delivery to ensure that decisions made by clinicians and patients are informed by current best evidence. Not current best literature, not what's been published, but current best evidence. So we've done a lot around pop-ups and alerts. We've decreased blood transfusions in our hospital by 50%, unnecessary utilization of transfusions. In fact, we've spread that now to 118 hospitals with the CRIT collaborative, CPOE, reducing inappropriate transfusions. We've improved sign-out workflow. We've increased our asthma home management plan of care compliance. And we even do a better job of hyperbilirubinemia management using a modular tool plugged into our vendor electronic health record called BillyTool, a little company I founded that makes no money. BillyTool.org has an open API on it that will connect to any EMR, Cerner, Epic, NextGen, eClinicalWorks. We've connected to dozens of hospitals. In fact, Dr. Madison, I would argue that your prediction about modular additions to vendor health record systems has already come true. Visit open.epic.com. You'll see the largest EMR vendor in the nation already has APIs available for uploading patient data. So when Dr. Sherrick came back to us and said, Chris, we're having a continued problem with central line infections, CABZs, ventilator-associated pneumonia, and we need some help thinking about how we can do this, I said, well, why don't we build something on top of our EMR? Let's innovate a solution. Went to the literature. Of course, Peter Pronovost has published widely that the checklist can help reduce CABZs in North Carolina and other populations. But we're in an electronic health record environment, and it turns out those checklists are really hard to maintain from a workflow standpoint. And we said, how can we integrate the checklist concept into our electronic health record? So that's what we did. This is not rocket science. This is not software of the future that's going to help create the singularity. This is simple conditional logic. Have you done the things that are recognized as best practices? And if you have, the electronic health record automatically shows it as green. If you haven't, it shows it as red. And if it's not applicable in that patient because they're not intubated, they don't have a central line, then it's grayed out. What we did, though, was not only create an EMR-enabled checklist, but we made it transparent. It's publicly visible in the unit. And now it's not just the people on the sharp edge of care that feel responsibility, it's everybody in the unit, including the unit clerk, including the parents. We worked with our Family Advisory Council. We put together a brochure so that when you're new to the ICU and you walk in, you see this board and your child's name's on it and there's a red dot next to it. It explains why that is and what we're doing about it. Well, we're Stanford. We think we do pretty well, you know. We've got to be top-notch in our compliance with these best practices, right? Here's some of the things recommended by the checklists integrated into our EMR. Adds less than 30 seconds to rounds for each patient. How many patients' care do you think was altered by this? We did time and motion studies, and in hundreds of patients, 1 out of 3 patients was getting different care because of something that's not interruptive, it's not popping up in your face, it's something that's transparent and publicly visible. So I was speaking with a bioethicist here yesterday who was aware of this Hastings report that came out in 2013. And I draw your attention to it because everything that we did on this EMR-enabled checklist, everything about hanging this up in a unit, we didn't regard as clinical research. We have regarded this as quality improvement. And I think that this Hastings Center's report is one of the most important reports to come out in the last 10 years. Because what this report argues is that we have a moral imperative to blur the lines between clinical research and quality improvement. When you visit Google, Yahoo, eBay, Amazon, every day you're part of an A/B test. Every day you're part of a split test to understand how can we make this site as user-friendly as possible? How can we have the best possible outcomes, sell the most books? And yet, we can't do the same thing with patients without layers upon layers of regulatory bureaucracy. In the absence of best practices published in the literature, like our 13-year-old girl with lupus, why wouldn't we randomize patients to understand constantly, to learn constantly? We have the technology to do this. It's easy. We don't have the regulatory and ethical frameworks yet to execute on this. So the question I'm going to leave you with, when you think about a girl like this, I have a 3-year-old daughter, and I'll tell you, if she was admitted to the hospital, this is exactly what I'd want my clinicians doing. How are we going to ensure that the healthcare system learns from every patient at every visit, every time? That's when we'll shift from evidence-based practice to practice-based evidence. Thank you very much.